we're going to invite Hervey Williams, who's a family physician from Umkhanyakude District in Eastern, in KZN.
Okay. Good day, everybody. I'm Hervey Williams. I'm the family physician in the Umkhanyakude DCST. My other title is Rusty Rural Handyman. I'm also accompanied by my colleague Sam Nkumani, who I think is here somewhere. Oh, there you are. Okay, thank you. I'm just going to tell you about us setting up a child health forum in our district. You probably know where Umkhanyakude is now after Venetia's presentation yesterday, but we're up by almost as far away from Cape Town as you can be in South Africa, but we're up by Mozambique and Swaziland. A rather scenic district. We're 1/5 game parks, and I had to find a reason to put a rhino in the presentation somehow. You might think we only have wildlife to treat, but and in fact some of our doctors do treat wildlife occasionally and sometimes have to go and discuss this with the HPCSA. But in between the game parks we have 650,000 people, we have 5 district hospitals, no regional or tertiary centres, and I think 57 clinics at last count. It's rather hard to keep count of all the clinics. But it's sort of simple. There's no regional. We have no specialists. That makes life simple. That's just another. This is where I used to work. I've been in the district now 22 years, actually, even though I'm an immigrant Brit. And that's the hospital I spent 14 years out on the left, and that's just a picture of pretty scenery. But Swaziland's the sort of lowland on the left, so you can. That's the Swazi border up there. Just to sort of set the scene. Why did we set up this Child Health Forum? I mean, partly we did it because Neil McKerrow told us to. But there were also other reasons for doing it. We were getting a lot of moans from our hospitals about paediatric service. I didn't quite understand these because in my day we didn't have any paediatricians to refer to, but anyway, there were a lot of moans about this. And when one went to visit the paediatricians, you got a lot of moans back. So it seemed to be desirable to get the 2 teams in the same room. And there was also a concern about malnutrition, and this is where I was a bit out of touch, but because back in 2008, kids mainly died of HIV, but by about 2012, HIV had gone down and malnutrition had become a main concern. So this was why we set up this Child Health Forum. Thinking how to do it, we already had a perinatal mortality meeting, and instinct initially was to combine the two, because creating meetings is something you should do with a rope around your neck. And if people disagree, well, that's too bad for you. But it was actually rejected to combine this because it was felt, as it was, we were having trouble finishing our perinatals on time, and the health professions involved weren't quite the same. And the first one we had in June, and we invited basically anyone who wanted to come, who was interested in childcare. And obviously the idea was to improve our childcare. Certainly a big aim for me was to somehow improve our collaboration with our pediatric specialist colleagues. And this, this has a lot of good spin-offs. If you're on the same page with your referral hospital, you have standard practices, standard ways of doing things. It's very important actually, and your referrals will work better, and you're all pulling in the same direction. Also for mutual education, and very important to create a bit of district glue, and if you like, a sort of bit of the district social club. I think I'm very strong on that actually. I mean, tea at 10 o'clock is a best practice in one of our hospitals. That's, the morale of the team spirit, the team cannot be underestimated as one of your most important healthcare healthcare tools. And we've gone for a kind of mini conference style. And it's important. It should not be the district's meeting. It should be owned by the participating hospitals. At the moment, either myself or Zama are chairing the meeting, but we may pass it on to somebody, and we rotate around hospitals. And each hospital does a presentation based on the child PIP statistics, fairly briefly, and then a case presentation. I think case presentations are usually the most interesting things, actually. That's where your problems arise and where real life takes over from the theory. And we give a specialist slot to our visiting specialist, and I've actually managed to get CPD points for the HPCSA registered people. After thinking about it for about 3 years, in the end it has been done. I've slipped in this slide. This is just to show some of the feedback on the stats we give. It's a bit heavy, but sort of green is good, yellow is worrying, and red is not very good. And you can kind of see there are hospitals along the top. You can kind of see that they're mainly green except for Hlab, which is rather red and yellow. And so it does very clearly indicate where we have a bit of a problem in our district. Now, improving the problem is another challenge altogether, and that a hospital that appreciates stats, cares about its stats, and responds to stats will probably have good stats in the first place. But it shows that we have we need to pay some attention at Labisa Hospital. Okay, that's just to show that. Some of the challenges, I said we have had a little bit of difficulty getting our paediatricians to attend after the initial, but in fact, the last year things have been good. So we have that was initially a little bit of a challenge. Hey, the competition from other events and meetings is unbelievable. I mean, it's just ridiculous. Even we had our most recent meeting on Wednesday, and on Monday I was given almost an instruction to go and do something else. That's just by the way. Obviously, from one end of our district to the other is 250k, which is quite small by South African standards, but it's still significant. And we don't have a district paediatrician in our district. So when you say there's a problem at Labisa, it'd be quite nice, as it was brought up on Wednesday, it'd be quite nice to have a district paediatrician to go in and troubleshoot. But that's one of our challenges. With a district paediatrician, it will probably become even more valuable an event. I think there's absolutely nothing to stop anybody else having a child health forum. I think it is a reasonable district function. It has to happen. I mean, I'm a bit of a believer in this, that anything that's worth happening has to happen grindingly, boringly, regularly, like a machine. And that goes for our DCST too. If it's optional, then it's not worth having. So for this to be valuable, it has to happen regularly, punctually, reliably. And I'm sort of prepared to turn up to it even if the president calls me to something or else, Okay. This is just to show, have we had any success? I think we can claim a decrease in our disease-specific mortality rates. Green is sort of good. This is a sort of shifting 12 months from 2012-13 to 15-16. But we can claim some improvement. I think, again, as any other district can do this, there's a lot of benefits, especially, I think, with team spirit and relations with your specialist team, and it gives you better outcomes. The format is changing. We add new statistics as we get caught with our trousers down, like we have found our immunization rate was low, so now that's looked at every meeting. Our AFP is looked at, like the lady from NDOH asked yesterday. So it's a very important feedback for our statistics. And the question, we're a little bit hospital-based. Perhaps we should be more PHC-based. But again, you've got to, rounding up people from 50 clinics is harder than from 5 hospitals. So there's that sort of question. anyway, it's sort of still evolving. Thank you. That's it.